This is Dr. Wyche Coleman, video 6 of 6 in the basic cataract series. And this is basically the final steps of cataract surgery. We've gone through separately making incisions, capsulorhexis, hydrodissection, nucleus removal, cortex removal, all using the divide and conquer technique. So this is closing up, and the interesting thing about this is the longest video. So although I think you can't alter the speed of this that much, I think people who do not use ProVisc at the end of the case and just use BSS, you can probably speed it up a little bit. I may look towards doing that at some point in the future after realizing how long these steps take. This video series has been informative to me to try to analyze where I'm wasting time surgically and where I can improve my average case time. On these videos, I think is about 6.5 minutes, maybe 7, somewhere in that range, which is pretty good, but there's always room for improvement. Although I was taught by my mentor 2 things that were key to good cataract surgery. Number 1 is perfect is the enemy of good, and number 2, slow is smooth and smooth is fast. And I always keep those 2 things in mind. The fastest cataract cases I've ever done certainly have been the ones where I was not trying to go fast. My current personal record is 4 minutes and 22 seconds, and I get a lot sub 5 minutes, but if I look at the clock and think about how long it's taking, I inevitably am moving slower. And if you want to see what the total case time is, on these, you can look at the counter in the top left corner on the Ingenuity. So that's the total time, and this one's 7 minutes, so we'll see what the average is. So, in general, I'm going to talk through these cases as I've done in the previous ones, not necessarily in the order that's occurring on the screen, at least initially. So, you know, the key to getting a wound that seals well is to have a well-constructed wound to start with. We all know that. If you have a long wound, if you have a short wound, they can torture you the whole case for different reasons. So every step builds on the previous step, and trying to get consistency surrounding those steps is critical. That's the reason that I made these videos. So if you're struggling with one step, and you'll notice through your career that you'll have something perfected, and then one day your paracentesis wounds are leaking and you have no idea why. Hopefully you can go back and watch this video and maybe help identify the problem. That's happened to me several times where I hit a mental block, and you know, nothing's perfect, and you get better over time, and consistency gets better, and at some point you don't have those problems anymore. For the record, I'm about a little under 20,000 cases in at this point. I'm 12 years into practice. I still feel like I'm still improving. You know, obviously improvement is very fast early on and slower later. If you're at a program or you were trained in a technique that's different than this, I would encourage everybody to adopt this technique. Myself, my partner, do the same technique. We were trained at LSU Shreveport. Essentially, all the cataract surgeons from there use a similar technique. My capsular rupture rate in an uncomplicated case is less than 1 per 1,000. So is my partner, Chris Shelby. So I think this technique is efficient, and it's very safe, and it works on 99% of eyes. As I said before, if you can't phaco it using this technique, it's probably time to do SICS. You're not going to be able to phaco it at all. So, filling the eye with viscoelastic. When we get the cortex removed, we're ready for lens insertion. We don't want to just fill the anterior chamber, because that's a common technique flaw I see with the residents and our fellows in their early stages of training. By the way, we do offer a cataract refractive fellowship for 1 year. If you're finishing residency and you watch these videos and liked them, please apply for it. Get some real-world coaching, and I promise you will perfect this technique. Our current fellow is doing cases that are about the same amount of time. I watch him operate sometimes, and I think if you showed me a video of him operating, I would not know it wasn't me. So I think his technique's excellent. Check out our fellowship, Willis-Knighton Eye Institute, Shreveport, Louisiana. Not an illustrious town, but pretty good training. So the filling with viscoelastic, we want to make sure that we don't just fill the anterior chamber. You do want to fill some anterior chamber, but you don't want to push the anterior capsular leaflet back and collapse the bag. That's where you're going to put the lens in just a second. So you want to create some space there. Now, we worry about pointing the cannula tip posterior because we don't want to rupture the capsule at the end of the case. We don't want the cannula tip to go through the posterior capsule. Remember, if you are actively injecting viscoelastic, and this is Provisc, cohesive rather than dispersive viscoelastic, whichever one you use is fine. I have no strong preference over between the different viscoelastic products. You want to make sure that you remember that if you have a fluid wave, if you are actively injecting, you cannot puncture the capsule because there's a fluid wave propagating in front of the cannula tip where the puncture would have to occur. You'd have to do something very aggressive. So the time that you would puncture the capsule with the cannula is when you're not injecting and you're pointing posterior. So I always want to inject a little bit of viscoelastic in the anterior chamber and then fill the bag and then let the eye fill back up from that direction. And when it starts burping back out the main wound, I think you're pretty much done. Another point would be to look at the paracentesis wound before you decide to go through the main wound to inject your viscoelastic, because a lot of times you'll have a small piece of nucleus that gets stuck at that paracentesis and you don't realize it until you hydrodissect the paracentesis at the end. Then you got to get the IA back out, go back in the eye, reseal the wounds, start the process over. The way to avoid that is to inject your viscoelastic through the paracentesis. Works fine. And that way you get that small piece of nucleus moving and out in the open where you can get it as you're removing your viscoelastic and you don't have to do it as a separate, distinct step. So viscoelastic is injected typically through the main wound, through the paracentesis if you need it to dislodge a small piece of nucleus that's stuck there. I inject bevel up. I do not stabilize the eye. I can stabilize the eye by pointing down with my lens injector with the end of the cartridge, and I usually do not have to use a second instrument in the paracentesis to stabilize the eye. I think it makes a paracentesis leak slightly more often to do that. Now, my partner differs on this. He uses the Connor in the paracentesis to stabilize the eye and goes in bevel down rather than bevel up. If I said bevel down, I go bevel up, he goes bevel down. Both seem to work fine. The theory that you want to go that you need to go bevel up comes from the idea that you're going to nick the endothelium by going bevel down. I'm not sure that's really true. I think the nicking of the endothelium occurs with the phaco tip, and I'm more careful to insert it with some down trajectory to not nick the epithelium and dislodge, or the endothelium, and dislodge some of it there. So I think bevel up, bevel down is fine. I think stabilizing in the para is fine, but I do not think it is necessary. I generally prefer my technique. So once the lens is injected, we want it to go in the capsular bag, but not point so deep. You're only pointing down to the point that you get it under the anterior capsular leaflet. That's where it's got to be. Don't keep pushing down and bulldoze through the posterior capsular. I've seen it happen a couple times in resident cases. So once it's under the anterior leaflet, then you can flatten out and just push it equatorial. You don't want the whole capsular bag complex to move as you're injecting in. So if you see that happening, that's when you start coming out of the eye in the final portion of the injection, so you don't destabilize zonules right at the end of the case. We'll talk this one through as it's going. So viscoelastic into the anterior chamber. Now I'm pointing posterior to make sure that we adequately fill the capsular bag. If you're doing an aura, getting uniform fill is really critical too. So bevel up, no second instrument, leading haptic. Remember, it's going to go clockwise, whichever way it's loaded. It should be loaded facing up, like rolled up like a taco. Sometimes it's not. Be aware, you can rotate if you have to. And if you're using silicone lenses, light adjustable lenses, 3-piece lenses, they come out in more of an explosion rather than a controlled way like a single-piece lens. So sometimes a lot more rotation is required. So to remove the viscoelastic, I'm removing it in the anterior chamber, anterior to the lens first. I'm always going behind the lens. And that's a scooching over of the lens motion. You want to push down on it and scoot it over and then sneak in behind it. We want to move it out of the way, the minimal amount, so we don't disrupt and stretch zonules to get behind the lens? Is it absolutely necessary to go behind the lens? I don't think it is, but if you're more than 100 cases in, I think that's the time that a resident should start going behind the lens to get the viscoelastic out, because especially with a toric, it's going to give you a pivot point to rotate on. I think it's more likely for a toric to rotate if you don't get adequate viscoelastic removal. So I think going behind the lens is a good idea. Now, if you have a complicated case, if you end up doing a vitrectomy, putting a lens in the sulcus, if you're worried that everything's destabilized, if you use a capsular tension ring, which I'm a big fan of, don't feel pressure to go behind the lens. Leave all the viscoelastic you want, and if they're not a contraindication, give the patient Diamox, give them topical drops, give them Combigan. Don't push a bad situation trying to get every little bit of viscoelastic out of the eye. If you use Diamox, their pressure will come down. Okay, so we're filling the anterior chamber, capsular bag, bevel up. Try to get the bubbles out of the end of the cartridge before I go in, so I don't end up with a big bubble sitting right in the middle of my view. I'm going under the anterior capsular leaflet, making sure it's there. Again, the Connor wand, I think it's the most versatile instrument ever made. Handles the lens just fine. Pushing it into the posterior chamber. Letting the haptics fold out slightly. It's important not to load the lens too long before you put it in, or it'll take a long time to unfold, especially if your OR is cold. We're going to go in and wash in the anterior chamber. I'm going to rock as I do. And if there were any small pieces of nucleus hiding, I want to stir them up now. I'm going to scoot the lens over to the left, lift up behind it. And I said in my video about cortex that almost the only time that posterior capsule is engaged is when the hole at the end of the IA tip is turned to the sideways or facing down. So you've got to make it point sideways to move the lens over, get in behind it, and lift it up. But once you're in that position, I must stop and comment on iris prolapse. That was because of flow. So flow causes iris prolapse. Fluid going in, fluid coming out. And I think I missed in my cortex video a very important point. I'll put it in now, that it's the one time you would go in position 0 in the eye. You know, you would go to position 0 if you have iris prolapse. Let the fluid stabilize, the pressure equalize, then ease out. Otherwise, you always want to stay in position 1 in the eye. Now here, we were able to seal the wound. We were able to get the iris back in the eye. But anytime you see iris prolapse, it never gets better, it just gets worse. So the more you fool with it, the worse the iris is going to be about prolapsing out of the eye. So the idea is to get it back in as few steps as possible. And once the wound is sealed, don't touch it again. If you need to put a stitch in, you can, but if the wound seals and the iris is not near the surgical wound, it's not necessary, because sometimes you'll go to put a stitch in a sealed wound, it will unseal, it'll be burped, the iris prolapses again. And, you know, now maybe you got to stitch through it. Now we got a real problem on our hands. So I'm going to make sure that I meticulously hydrate without burping and without overpressurizing the eye, because I don't want to create flow back out that wound. So position 0 when you're doing IA, and at this point we want to minimize flow. We want to make sure that we don't overpressurize the eye like we did the first time, which led to the iris prolapse. So we've gone over viscoelastic injection, lens injection, removing viscoelastic from behind the lens. I will say we use cefuroxime as a standard in every case. If they're a cephalosporin allergy, we use Vigamox. I think probably either is fine. This has dramatically reduced our endophthalmitis rate to something below 1 per 18,000, which is the number of cases we've done since we implemented intracameral antibiotics many years ago. Have not seen endophthalmitis since. So I think that's a very important step, especially in training programs. So now to hydration of the wounds. When I'm thinking about hydrating a wound, I'm thinking about the distance from the inner to the outer portion of the wound. And I want to basically divide that in half. So let's say that the main wound is 2.5 millimeters long. I'm going at a point about 1.25 millimeters halfway, and I want to be as perpendicular as possible to the direction of the main wound. So, and I want to place the tip of my cannula at that point, 1/2 the distance between the inner and the outer edges of the wound. I don't want to move the eye around a lot, but I want to put enough pressure there to where it's very definitively in that position. And that's where I'm going to hydrate. And usually you can hydrate on one side with that method, then the other side of the main wound. The paracentesis can most times be hydrated just on one side. It's important while you're doing this not to push down, because pushing down burps the wound. So we want to be in a real neutral position. We don't want to lift up. We don't want to push down. We don't want to ram the cannula in there so hard that the eye has a lot of movement to it. But we still want it pressed in the into the stroma enough that it's a very good definitive seated position before the hydration starts. Now, a common source of a main wound leak is the inner leaflet of the wound, especially if it has like a triangular edge on it, can flip back out. So it would be the lower portion of the wound can flip back out the wound. And even if you've done a good hydration, it will keep leaking. It'll persistently leak, even at a normal pressure. And my partner calls it a dirty burp. I don't know what the official term for it is, but basically what you want to do is lower the pressure in the eye, burp some BSS out of the main wound, and then put some back in without putting the cannula all the way in. Just barely let some flow come back in, and that inner leaflet will flip back the way it should go so it's not rolled back out of the wound, and the wound will suddenly seal. A wound that's been very cantankerous, if hydrated over and over, still leaks, that will suddenly seal it. The paracentesis, you'll have a tendency to be pressurizing the eye with the paracentesis if you're not careful. So be cognizant of that, because it can cause what you just saw, which is iris prolapse, in a case that hasn't had any problem with iris prolapse the whole case. The last step is intracameral antibiotic injection. That's done after everything else is done. I have seen videos where somebody will inject the intracameral antibiotic, then they'll hydrate the wounds. That doesn't make a lot of sense to me, because you're usually diluting yourself. I think it needs to be the last step once the wounds are sealed. I have to give credit to Uday Devgan. He showed us a great trick in our OR once to seal a wound that is persistently leaky at the end of the case. Anytime I have a leaky wound, first I want to check the pressure. I want to make sure the pressure is not 50, because even a nice tight wound will leak up with a pressure of 50, so make sure the pressure is relatively physiologic. If it's still leaking, you can hydrate some more. Check for the inner leaflet, rotate it in, do a little dirty burp, let it flow back in, and a lot of times that will seal it. If it's still leaking, don't put a stitch yet. Take a Wexel, soak the Wexel completely in tetracaine if you have access to it, where it's dripping off the end of the Wexel. Hold it on the wound for 1 minute. The theory behind this is that compared to corneal stroma, tetracaine is hypotonic. Water flows to the relatively hypertonic stroma, and it will diffusely hydrate around the wound in places that you can't just directly hydrate with the BSS cannula. That will save you a lot of stitches. I think there's some debate over whether we're just waiting longer and the time you're sitting there causes edema to happen anyway. I really feel like that's not the case, that tetracaine actually has some sealing effect through whatever mechanism, but it's been a great trick. It's saved me a whole lot of sutures. But I think that the question of whether to put a stitch or not is, if you've done those things and it's still leaking, or you think it's unstable and you think about putting a stitch, put a stitch. It's sort of like trypan blue. If you think about using trypan blue, use trypan blue. If you think you might need to use iris hooks for a small pupil or a Malugin ring, use the dilating device. So if you're thinking about doing it, it probably means that you should, and the same would be true for a stitch at the end of the case. So here we're going behind the lens, centering the lens back up by just pushing down on the center of it. These optics are pretty tough. This works well even with light adjustable lens. It works fine. We'll have a separate video up at some point rotating toric lenses into the proper position, but it's similar to what we were just doing. I think it is worth thinking about where your haptics are when you put the lens in the eye to make sure that they're not blocking you from going behind the lens. If there's a small piece of cortex left, you can take it at this point with the lens in the eye. Sometimes that's safer. And you want to bring the lens over to the cortex with you. And sometimes if the cortex is especially sticky, you can rotate the lens 180 or 360 to loosen the cortex. But you don't want to push the lens away. Let's imagine you've got subincisional cortex. You don't want to push the lens, the IOL that is, distal to the wound to go try to get that. You want to bring that lens with you and preferably take a haptic over there, because that protects you from bringing posterior capsule forward while you're towing in and reaching underneath the surgical wound to get that last piece of remaining cortex. So I see people push the lens away. Don't do that. Bring it with you. Lens is in the posterior capsule. Remember, we don't have to keep pointing down once it's under that anterior capsular leaflet. Distally, I'm thinking about where these haptics are. I'm sure they're not going to block me when I want to go behind the lens. I'm rocking in the anterior chamber. This is basically floored. I've got the foot pedal to the floor, aggressively rinsing all the viscoelastic out. Now I'm going to nudge the lens over out of the way. Just as much movement as I need. I'm looking straight down that port as I remove the viscoelastic from behind it, because I know that's safe. I can't get posterior capsule there. Final rinse in the anterior chamber. Go into position 1 because I don't have iris prolapse. But if I did, I would have gone to 0 and come out slowly rather than coming out quickly. Picking a point halfway between the inner and outer edges of that wound, going as perpendicular as I can. Hydrating, that's the dirty burp. A little bit of fluid back through to get that inner leaflet rolled in. Hydrating 1/2 of my paracentesis should be adequate. Checking with my Wyche cells. They're sealed tight. Cefuroxime intracameral. Hope everybody's enjoyed this video series. This is the final one, 6 of 6. Thanks for watching CyberSight, and please give us your feedback. If you enjoyed this, please share it.